Okay, welcome to the mental status examination lecture. My name is Haytham Tayyib. I am a consultant in neurology, behavioral neurology or neuropsychiatry and epileptology, and an assistant professor at the King Abdulaziz University um, faculties of medicine in the main branch in Rabat. This lecture, of course, I will give in both English and Arabic to serve the purposes. So في البداية we need to know what the word cognition means. Cognition means إدراك, which is the set of thinking skills and القدرات الإدراكية التي لدى الإنسان. ومنها تأتي كلمة to know. So the K is silent, so know is similar to cognition, so the two words are related. And then there's the word domains, which means the separate areas of thinking that a human can have, or an animal for that matter. So uh, بعض الناس يفكروا في الcognition على إنه it's just one entity. Someone is either smart or stupid. But as a matter of fact, we know that cognition is formed of multiple domains and areas. هذه areas are dependent on each other. They interact, but they are separate. And some of them are more basic and important and required for the function of others. So, for example, if you are not awake and not attentive, which is at the base of the pyramid, you will not be able to perform any functions at all. So this is the base of the pyramid, and you need it to perform functions that are higher in the pyramid. So the first thing we assess when we assess the mental status examination is wakefulness and attention. And then we assess language and memory, which are next in the pyramid. And then we go ahead and perform specific examinations of specific parts of the cerebral cortex. For example, perform a frontal lobe examination, a parietal lobe examination, a temporal lobe examination, and so on and so forth. Subsequently, we perform what we call a mental status, the psychiatric mental status examination, which includes assessing things like insight and judgment and looking for delusions and thought process and so on and so forth. So the process can be long, but it also depends on what you're looking for, and we don't do everything in every patient, except for the basic things. So we typically, and most importantly, always assess arousal and wakefulness, and we should always assess attention. And then, depending on our circumstances and the clinical needs, we can assess language and memory. And neuropsychologists summarize all of this into 5 domains named for you here, and we'll go over them one by one. So we'll start with arousal or wakefulness. So people are not either, or it's not a dichotomous position. People are not either awake or asleep. There is a gradient. So you can be fully awake and alert. You can be awake, but you could be inattentive. You can be a little drowsy. You can be a lot drowsy or lethargic. You can be lethargic but difficult to arouse, which we call stupor. And then when you're comatose, you're so deep that there's little response that comes out of you. And these words are subjective. So when I say lethargic or drowsy, it may be different from when you say lethargic or drowsy. So we typically try to standardize the way we describe it, and we use what we call the Glasgow scale, which is what you see here. And it depends on eye responses, motor responses, and verbal responses. So if the person is opening their eyes spontaneously, you give them a 4. If they obey your commands, you tell them to do something and they do it, you give them a 6. If they are speaking easily and they're oriented, you give them a 5. And that's a total of 15, which is the normal score. And if people are a little confused, they can get anywhere from 14 to 12. And typically, if your Glasgow's is 8, you are close to being unable to protect your respiratory airway, and therefore, maybe you need to be endotrachally intubated. All right, so let's start to talk about attention. Attention is someone's ability to control their cognition and direct it towards a particular stimulus. So, for example, if you are listening to this lecture and you suddenly see a snake crawling on the ground, you will immediately and in an obligatory way, involuntarily, completely have your eyes and hearing and your body posture change in order to save yourself from a potential snake bite. So that is called the attentional spotlight. احنا نسميه بالعربي الانتباه ولكن يندرج تحته أشياء كثيرة. So there's sustained attention and there's selective attention. So your ability to shift your attention towards that snake is called selective attention. Sustained attention is what you are using to listen to this lecture in a longitudinal way and to gather enough information to try to gather information from it. And there's the word working memory. Working memory is another word for attention, and it's either simple or complex. Working memory is your ability to obtain information from the environment and then give it back. So, for example, if I say repeat 1, 2, 3, you hear me say 1, 2, 3, you give it back to me 1, 2, 3. That's your ability to that's your working memory. It's like the RAM in the computer. It's not the hard drive storage, it's the RAM storage. It's information that stays in your brain temporarily, and you don't really encode it for long term. And you can also manipulate this information. So if I say 975 and then repeat it backwards, we call that complex attention, which means you hold something in your brain, you manipulate it a little bit, and then you completely forget about it. As a matter of fact, do you remember the numbers I just said? You may or may not remember. If you remember, they're still in your working memory. And if you don't, it means they just got erased because you didn't intend to encode them. So this is also called short-term memory, by the way. So whenever we say short-term memory, the correct terminology is that this is working memory, and it does not mean memory that happened in the recent past. All right, moving on to the tests that we can use. So the tests that we can use to test working memory include the digit span, which is what I just basically did to you. What you do is you ask the patient to repeat the digits, and you can do that with me. Repeat 9, 8, 1. The patient will say 9, 8, 1, and then you go up to 4 digits. Repeat 6, 1, 4, 9. The patient will say 6, 1, 4, 9. Then you go up, you increase the number of digits, and you ask the patient to give it back to you immediately. And the normal digit span is basically the lower limit of it is 5, which means that anybody who has a digit span less than 5 is probably inattentive. And someone who is educated, you expect them to have a digit span of 7 at least, but 5 is the absolute lower limit. Another way to test sustained attention is to ask someone to spell a word backward, like the word world or hospital. I typically use مستشفى بالعربي مثلا أو ملعب. It depends. You look for a 4 or 5 lettered word and you ask someone to spell it and then you ask them to spell it backwards. So مستشفى would be ألف فاء شين تاء سين ميم. You can also ask the patient to do your serial sevens. You ask them to start with 100 and then go down to 93. You say reduce, subtract 7 from 100 and keep subtracting sevens. So the patient will say 100 minus 7 is 93, minus 7 is 86, and so on and so forth. And someone with difficulties with attention might make errors here or there or forget what the previous number was, and they can screw it up. An additional test is what we call the continuous performance test, which you guys don't really need to worry about. And you read a series of letters in this test. So F, A, W, L, A, M. And what you need to do is you ask the patient to tap every time they hear the letter A, for example. And people can miss a few letter A's if they have poor attention. So these are all examples of tests to test attention. All right, so we have, to remind you, what we have done is we have gone through wakefulness and attention. We are telling you about the tests that you can use to examine these things. And testing attention, in fact, is extremely important because no matter what you do, you may end up seeing patients with delirium, which is another name for the acute confusional state, or encephalopathy is the other name for it. These are people who are confused, basically. So you don't have to be a neurologist in order to uh, be exposed to these patients. So this is a state of impaired attention, and it may be accompanied by behavioral dysregulation, which means people may tend to be agitated, or they may hallucinate, or maybe the opposite. They may be super quiet and uh, hypoactive. And what you see in these people is that they will have trouble with attention, so they will have difficulties with the tests that we showed, like the digit span. And because they have a difficulty with attention, which is at the base of the pyramid, they may have difficulties with all of the other cognitive domains that are higher up in the pyramid. So they will have problem with memory and problem with language, not because they have problems with the areas that are responsible for these cognitive functions, but because the basic requirement for these functions is not functioning properly, which is attention. All right, and if you see someone who's confused and who fits this description, you have to think about something dangerous. It means that they are ill. There's either a brain (CNS) or systemic infection, a severe infection going on, sepsis, some kind of electrolyte abnormality, renal failure, hepatic encephalopathy. The patient may have taken a drug, an illicit substance, and the list is long. And when you rotate in your internal medicine, you will see a lot of people who are confused and with urinary tract infections and pneumonias and so on. And sometimes that's the only thing you see. If you're in surgery and your patient just had a surgery and you come in and talk to them, there's no swelling, the wound looks clean, but they're a little off, they are inattentive. You should look more carefully for something else that's going on with them, examine them properly and look at the labs and so on. So attention is extremely important, and delirium is actually dangerous. All right. So we've done attention. Now we're on to the next cognitive function, which is language. Language, again, is not one thing. Language includes fluency, someone's ability to express themselves easily. It depends on the word output, the number of words that someone can say in 1 minute, for example. بالعربي الفصاحة. Comprehension, which means understanding. These are the two major um, linguistic functions that we have. And you may remember that there are two major brain areas in the dominant hemisphere, which is typically, as you may remember, it's typically the left hemisphere in right-handed people. And it's rarely the right hemisphere, because even left-handed people, as you may know, will have the left hemisphere as the dominant hemisphere. So right-handed people, 99% it's the left hemisphere, and 1% it's the right hemisphere, and left-handed people is something like 50-50 or so. So in the left side of the brain, usually, there are two major areas that are responsible for language. One is called Broca's area, and this is responsible for fluency. And one is called Wernicke's area, and that's Broca's area. This is Wernicke's area, and this is responsible for comprehension, understanding. And of course, these areas are connected, and they're connected to the rest of the brain, and it's the network is diffuse. But generally speaking, in the inferior part of the frontal lobe, there's an area called Broca's area, and this is responsible for fluency. And in the superior part of the temporal lobe, there's an area called Wernicke's area, and that's responsible for comprehension. And if you have a lesion in Broca's area, you have a non-fluent aphasia. So we call the Broca's aphasia is non-fluent. People will have difficulty with finding words, and they will have lots of pauses. Their speech they will lose grammar and so on. And then there's Wernicke's aphasia, where people will be fluent. They will not have trouble with producing words, but they will not understand, and they will not understand even themselves. So their speaking will be incomprehensible as well. They will be saying something like a word salad. Okay. So let me show you. I want you to tell me I want you to think, you could tell me later when we talk, whether this is Broca's aphasia or Wernicke's aphasia.
And what did you used to do?
Worked Autodesk, seven sales, and worldwide, and very good. Yeah.
Okay. And who are you looking at over there when you turn your head?
That's my wife.
Okay. And why is she helping you to talk?
So there was one patient, and
I mean, for them at the moment, they'll save in the moment. He'll have water very soon for him, with luck for him.
So we're on a cruise, and we're about to
We will store it right here, and they'll save their hands right there for them.
And what were we just doing with the iPad?
Right at the moment, they don't show a darn thing.
With the iPad that we were doing.
So as you can see, the first patient, this patient, had
And what did you used to do?
slow speech,
Well,
slow speech with lots of pauses,
worked
no grammar.
Autodesk 7.
Whereas this person is fluent.
here?
I'd like my
He can speak easily,
driving for
but
them at
he's
the
not
moment.
responding properly
They'll
to the
save in the
questions,
moment. He'll have water
and he
very
clearly
soon
doesn't understand.
for him. With luck for him.
So we're on a cruise and we're about to
We
get to
will
Juneau.
store it right here and they'll save their hands right there.
There you go. So I will let you figure it out which one is Broca's aphasia and which one is Wernicke's aphasia. Go back to the video and you'll figure it out. So what we do to test Broca's aphasia is we ask people to speak and we count the number of words they put out in 1 minute, for example. And if there's pauses and word finding difficulty and grammar problems, it's Broca's aphasia. And to test comprehension, what we do is ask people to do commands. We give them orders. And if we start with simple commands and then we go to complex commands. And so for example, we tell them to open your eyes, they will do it, they understand. Raise your arm, touch your right ear with your left hand, and so on. So you make the command more and more complex. You also test these other parts of language, repetition and naming when you need to. And when you ask people to name, you ask them to name parts of your objects. So you take your pen and you say, إيش هذا غطا القلم, إيش هذا حواجبي, and so on. You don't ask for people to name common nouns. You try to use words that are common enough that everyone should know, but are not the easiest words. All right. And you should also distinguish between aphasia and dysarthria. Aphasia is a trouble with language, which means the person's ability to transform ideas into syllables, the link between ideas and words, and or transform sound into ideas. So that's comprehension. That's basically what language is. Whereas dysarthria, people know the ideas, they know what they're going to say, they want to say exactly, but it's a problem with sound articulation. So articulation, the ability to move your tongue and throat the right way, is impaired. So people will, they will say correct. The content will be okay, but the sound will not sound okay. So they'll have slurred speech. And if they didn't have weakness, these people may be able to write, whereas people with aphasia may or may not be able to write. So dysarthria is a problem with maybe muscles, there's weakness in the oropharyngeal muscles. It could be dentures, for example. That's dysarthria. Whereas aphasia is a brain problem, is a cortical problem. It's either Broca's or Wernicke's, or if both, we call it global aphasia. All right, so we showed you this. Next, we will talk about memory. Memory is, again, not one thing. Just like language is not one thing and attention is not one thing. Memory can be divided into what we call explicit memories, which are memories that you can disclose and say. You can write it, you can say it, you can transfer it to me. And implicit memories, which are that you can't transfer them to me, you can't declare them. The other word for it is non-declarative compared to declarative. So explicit memories are either facts a cat has 4 legs, a Ferrari is fast. So it's like an encyclopedia. It's a bunch of information. And then there is events. What happened today, what happened yesterday, what happened last year, and so on and so forth. So we call this semantic memory. We call facts semantic memory. This is your encyclopedia. This is not time-bound. It has nothing to do with time. These are timeless facts. And events are episodes. We call it episodic memory as opposed to semantic memory. And the example for non-declarative memory is driving a bike, for example. So you can't really transfer to me how to drive a bike. You can describe it to me, but you can't just simply give it to me. I have to train myself to do it. That's why it's implicit and non-declarative. And there are several stages to acquire memory. First is the stage of registration, followed by the stage of encoding and the stage of retrieval. Registration is attention. It's your ability to have the information get in your brain. Encoding is when you transfer the information into a long-lasting neuronal representation in your brain. And retrieval is when you reactivate those neuronal representations in order to bring the memory back. So registration is to write the information on a file, for example. And encoding is to put the file in a cabinet تحطه في درج في مكان ما. And retrieval is when you go to that cabinet, the exact location that you put it in, and you retrieve the information. And each of these can be impaired, and therefore we have to pay attention when we test memory, the way I will show you now, to know where the deficit is. So the tests are for episodic memory. We give patients typically 3 words or 5 words, and we ask them to repeat them several times. That's the stage of registration. We make sure that they got the words, that they repeated them several times. We then distract them, and we have them tell us the words later on. And that's the easiest way to test for episodic memory. You can also ask patients to tell you about events in their life. So, for example, things like, did someone get married in your family recently, and they have to tell you who it is, or died in your family recently, and you ask the family member with you whether that was right or wrong. Or you can ask about events in the news, for example. So if we were in the clinic right now, I would ask someone about why there's was a quarantine in 2020 and where the disease started and how many cases there are in Saudi Arabia and so on and so forth. And the more educated the person is, the harder the questions you ask should be, and the more you expect them to answer. And for semantic memory, you ask them about facts. For example, you show them pictures of, say, a cat, and you say, do you eat a cat, for example? Or you say, does this fly, and so on and so forth. But we rarely test semantic memory unless we have to. For non-procedural memory, we ask patients to draw things and to demonstrate motor activities. We also rarely do things. So for your purposes, testing word registration and recall is the most important thing for you to test in memory. But you can also do story recall, like I said, where you ask questions about the news. So amnesia is loss of memory and can be due to impaired registration. The brain simply does not register the words that you are giving to the patient. Things happen in the surroundings of the patient and the brain does not register them. And we call this impaired registration, and it's a problem of attention. And we've already given attention a few minutes in the beginning of this video. So people with delirium, for example, will not remember things that happen to them while they are confused and encephalopathic. Another important cause for impaired registration is anxiety, depression, sleep deprivation. Your IQ goes down and your attention goes down when you're asleep, when you don't sleep properly. And then there's people with attention deficit disorder, people with hypertension and diabetes who have a lot of strokes in their frontal lobes have what's called vascular cognitive impairment and may have trouble with the registration of the information as well. Retrieval of the information, if you register, encode, memorize the information, and I ask you about them later, and you have difficulty bringing them out, but you succeed after me helping you, it means that you registered and encoded the information, but you have difficulty in retrieving the information. So bringing it out from the drawer in which you stored it. And again, the causes here are similar: anxiety, depression, and vascular cognitive impairment, Parkinson's disease, and other things that affect the frontal lobe. The frontal lobe is important in both retrieval and registration. So the causes are somewhat similar. Whereas the causes of impaired encoding are slightly different. This is a temporal lobe problem. And the causes include Alzheimer's disease, which is a very common disease that we'll get to talk about later. In someone with alcoholism or malnutrition, Wernicke's encephalopathy can cause trouble with encoding, and there are other causes as well. And people with difficulty encoding memories, they will be able to register. They will not be able to retrieve the memory, obviously, but they are also not helped. When you try to help them, they will not be, it will be as if you never told them the information to begin with. So in people with Alzheimer's disease, you can come in, introduce yourself, you say your name, and then after 2 minutes, they'll ask you who you are and what your name was. And no matter how much you try to help them, it will not work in the late stages of the disease, that is. So what we do is we give people 5 words. So say the 5 words are face, velvet. These words are from one of the famous tests, and red. People with registration difficulties will have to repeat the words multiple times, 10 times, in order to memorize them. People with retrieval difficulties will say, get back one of the 3, and then you say, well, one of them was a color, and then they'll say, oh yes, it's red. So they were able to encode it, but had difficulty retrieving it. Whereas if someone did not encode it at all, you'll say it's a color, they will not remember, and so on and so forth. So the word was not encoded at all. So that's how you differentiate between retrieval and encoding. All right, so, and when people have trouble with registration or retrieval, just to emphasize, trouble is with the frontal lobe, and if they have trouble with encoding, it's a problem. It's a mesial temporal problem in the medial part of the temporal lobe, and semantic memory is basically in the anterior part of the temporal lobe. All right, so we're done with memory. Now, when we're almost done with cognitive domains, we'll discuss visuospatial functions or visual functions, القدرات البصرية والفراغية. And these start with the occipital lobe, obviously. And then there is this higher visual processing. This is primary visual processing, and then there's higher visual processing along the temporal lobe and the parietal lobe. So the temporal lobe processes what things are. So things like form and color. And the parietal lobe assesses things like location and speed and so on. So, and the combination of these gives someone the ability to perceive things in the environment visually normally. The other visuospatial function of concern, other than perception, is construction, or the ability to draw things and so on. So, what we do is we test these things by asking the patient to draw a clock. So that's construction. And then we ask the patient to describe a picture. That's the perception part. So what we do is tell the patient, take a piece of paper and draw a big circle and draw a clock and put the arms of the clock at 10 past 10, for example. So this is how a normal clock would look like. 12, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. And someone will, if you say 10 past 10, it'll be like this. And people can commit many mistakes. So someone with who is disorganized and have visuospatial executive problems, planning problems, they will, for example, have problems with the distances between the numbers. They may end up cramming a lot of the numbers, for example, on one side, in what we call visuospatial neglect. So people will finish number 12 here, 11, 10, and so on, and completely neglect the left part of the space. So this is called neglect. And this is evidence of a major right hemispheric problem. Or if people have a parietal lobe problem, for example, and they may not be able to draw the circle properly, they may misplace the hands, and the clock may be misshapen. So something might look like this, for example, and the numbers will all be in the center. So this will be a bad clock, and it's evidence of poor construction. All right, and you can show someone a picture like this, for example, and give yourself a second to describe the picture, and then you ask them what is missing of the picture. And hopefully you recognize that, for example, there's a missing hand of the female figure here. It's not present in the mirror. Finally, last but not least, there's the examination of the frontal lobe. For purposes of ease, we divide the frontal lobe into lateral aspects of the frontal lobe, lateral and inferior orbitofrontal parts of the frontal lobe, and medial parts of the frontal lobe. And each surface of these surfaces is responsible for a particular function. So the lateral part is responsible for executive functions, things like planning and changing plans when things happen, and flexibility, and so on. The orbitofrontal lobe is responsible for restraint. Restraint is the ability to stop yourself from being impulsive, and if you have a problem here, people become disinhibited and they perform socially inappropriate things. And the medial part of the frontal lobe is essentially responsible for motivation. So people who have problems here will have low motivation, will not want to do things, and will not ask for water even if they are thirsty. And most of these things you observe on if the patient is in the hospital in front of you, or you ask the family to about them. And so this is what you do. You ask your family about motivation, restraint, and how the social behavior is going. And then you can test planning and executive functions with one of many of these tests. So for example, the Luria sequence is a test where you ask patients to connect a series of letters and numbers, and you tell them that you want to connect all of these numbers and letters, but you don't want to go 1, 2, 3, 4. You want to go 1, A, 2, and then if they were to answer normally, they would say B, 3, C, 4, and so on. So it's called the Trails A test. The Luria sequence is this. You ask patients to draw a series of square triangle, square triangle, square triangle, and if they have executive dysfunction, they will forget that they are supposed to alternate, and they may just continue like this, or they will do 2 triangles and so on. So this part is normal, this part is wrong, and it's evidence of frontal lobe dysfunction. And many of these tests are compiled for you in assessment tools. You get one paper and you do these tests, but without understanding the different components of the test, you will not be able to understand and interpret the cognitive examination, and therefore you have to approach the cognitive examination with the idea that the cognitive exam is addresses multiple cognitive domains that are independent of each other and that should be assessed separately. Thank you.